Okay, this is Dr. Wendy Burdo-Hartman, and I am giving a presentation on vomiting in the NICU population. My disclosure for this lecture is that I'm receiving an honoraria from Dr. Brown. I have no other conflicts of interest. Vomiting in the NICU is a very common issue and can lead to problems for these babies when it comes to feeding and development. Treatment can be controversial. If not treated, many infants have trouble advancing to full feeding. After attending this webinar, the participant will be able to list at least 2 causes of vomiting in the NICU, describe the clinical scenarios where thickening feedings may be appropriate in the NICU, and outline a post-discharge plan for infants who experience persistent vomiting in the NICU. The scope of the problem. First, let's do some definitions. Regurgitation or vomiting is movement of the gastric contents into the mouth. Gastroesophageal reflux, or GER, is retrograde movement of the gastric contents into the esophagus or above. And gastroesophageal reflux disease is when the gastroesophageal reflux leads to symptoms that lead to other medical problems and requires treatment. Who are affected by vomiting? This includes the infants, the patients in the NICU, their parents, and the NICU staff. So as far as the infants are concerned, first and foremost, the vomiting may cause pain, which can affect their quality of life in the NICU. It also may affect their lung disease, which is very common in the NICU population. This can lead to bronchospasm, which requires more medication treatments. There can be aspiration of the refluxate that goes into the esophagus and above, leading to inflammation in the airways. It also can lead to poor growth. These infants have higher caloric needs than term healthy infants. This can mean higher feeding volumes, which may lead to more vomiting. This also can cause feeding issues. Vomiting associated with feedings can lead to negative learning experiences or history, and the infant then associates those feedings with that discomfort. The other problem that can happen is prolonged hospital stay. If not tolerating feedings, either by tube or by mouth, the infant needs to stay in the hospital. And the American Academy of Pediatrics actually recommends that the infant should be on full oral feedings or a gastrostomy tube feeding before they leave. This prolonged hospital stay can lead to higher risk for the infant of getting more infections or nosocomial infections, and also can be associated with greater developmental delays. Think about the parents. It's hard to watch your child be in the NICU no matter what, but then if they're vomiting on a regular basis, this can lead to more stress for the parent. It raises concern that something is wrong, and they're wondering, is there another problem that needs to be addressed or is being missed? Sometimes they think there may be an allergy to the formula that they're being fed. This may affect relationships between the parent and the child. If the parent is anxious about vomiting, this can be felt by the child. If that child is irritable because of the discomfort from vomiting, then that parent may not be as bonded to that child. Also, the child vomits when they are moved, then they may not be being held as much by the parents, and there may be a decrease in engagement. The parents are also concerned about the prolonged hospitalization. This creates more worry for the family. Many families are spending time away from their other children, or one parent may need to be at home with the other children and the other at the hospital. Also time away from work, and this can lead to financial stressors for the family. As far as the NICU staff, it's hard for you to watch the patient vomit, particularly if it's uncomfortable. It also may affect your workflow, changing infants' clothes, having to change trach ties if the child has a tracheostomy. The bedclothes have to be changed several times a day. It also interferes with therapists and their ability to give the child therapies. If movement or increased challenge for the child leads to more vomiting, then their ability to participate in that therapy is limited. It may affect your relationship with your parents if they're or patients if they're irritable because of discomfort. It may affect your relationship with the parent. Parents are often anxious about their child's health, and the vomiting is a concern for them. One of your only options is offering reassurance, and that can sometimes feel like not enough, and you have to sometimes be an advocate for them with the medical team. As far as the differential diagnosis or the causes of why there may be vomiting in the patient, these can be many. Some of the most obvious are that there may be congenital anomalies of the gastrointestinal tract. Esophageal atresia, tracheoesophageal atresia, gastroschisis, omphalocele typically are fairly well identified early on. Duodenal webs or atresias may take a little longer to find. Hiatal hernias, other abdominal wall defects, malrotation, again, may not present immediately at birth, but will show up a little later. Kids with diaphragmatic hernias can present with vomiting and other issues. Kids who have central nervous system problems, affects their ability to tolerate feedings and sometimes leads to dysmotility in the gastrointestinal tract, such as delayed gastric emptying. Medications can cause problems with motility in the gastrointestinal tract and lead to vomiting. Sometimes they have osmolarities that are very high. This can cause irritation in the stomach and lead to vomiting. If there are other organ systems that are not functioning well, such as the lungs, and the child has bronchopulmonary dysplasia or other chronic lung disease, this can slow down gastric emptying as well and lead to more vomiting. Congenital heart defects, heart problems can lead to, again, poor functioning of the gastrointestinal tract, and when the heart is not working well, will lead to the child having vomiting. If kids have kidney anomalies, that can sometimes affect the function of the gastrointestinal tract, but also they require high volumes of fluid that can just naturally be overwhelming for the child's GI tract and cause vomiting. Inflammation in general can cause irritation in the gastrointestinal tract. If there is chronic lung disease or infection, the body is dealing with inflammation and makes things not work well. Stress is multifactorial, but any child who's in the NICU can have problems with stress. The environment is sometimes loud. Sometimes there's a lot of pain with needle pokes and other suctioning and other things that are going on. This can all be stressful for the infant and cause them to have vomiting. Move on to assessment of the child with vomiting. One of the first things we always do is look at the history of the child. Birth factors need to be assessed. If there was a prolonged delivery, this can sometimes lead to problems. If resuscitation was needed, Maternal factors such as diabetes, drug use, all can contribute to problems with the gastrointestinal tract and its motility and lead to vomiting. Is there a lot of respiratory support needed? Did they require prolonged intubation? Were they on prolonged CPAP? These things can all cause irritation and can cause increased air to be pushed into the GI tract, leading to increased vomiting and feeding intolerance. Medications that are needed during that time period can be sedative medications, narcotic medication, benzodiazepines, steroids, all which can have effect on the gastrointestinal tract. Neurologic issues that can occur in particular premature babies, such as hypoxic injury. There can be intraventricular hemorrhages that can lead to problems in the system in general. Hydrocephalus can have increased intracranial pressure, which leads to vomiting. Other kind of congenital malformations in the brain can cause these issues as well. Things to look at with the vomiting itself is, how much volume are we talking about when the vomiting is occurring? Is this whole feedings that are being lost? Are these small spit ups? How often are they occurring? Also looking at the color of the emesis. If it's bilious, there could be more concern for obstruction. Is there blood present? This could be a sign that there's gastritis or esophagitis. Also, those being signs that the infant is under stress. Abdominal distension could be signs of formula intolerance, but this leads to discomfort. Looking at other bowel history, such as is there diarrhea, which may be a sign of formula intolerance. Constipation is not uncommon in infants and can lead to problems with vomiting. Different procedures that we might use to help us determine the cause of the vomiting may be something to look at the anatomy of the esophagus and the stomach. The most common procedure is the upper gastrointestinal study. This is really to assess, again, anatomy. It may show us reflux, but that is not the primary reason that we would do that study. And indeed, if we don't see reflux on that study, it doesn't mean that reflux isn't happening. They also may do gastric emptying studies. It may help us decide on medications that might be used. It also may help us decide whether we should use a more extensively hydrolyzed formula. But one of the challenges with the gastric emptying study is we don't have really good data on what the normals are for infants, and particularly premature infants. We could do an abdominal x-ray. This may show us in general signs of obstruction, may show us air fluid levels that then would lead us to look more for a surgical problem. Other studies, maybe a pH impedance study. This will tell us whether the reflux or the vomiting is acidic or not. It still can mean that there is reflux, but it may tell us whether anti-reflux medications will help the child with their problem. Esophageal manometry studies may be helpful. Not all institutions have these to be able to do them, but where they are available, it could help us determine what the upper esophageal sphincter function is, as well as the lower esophageal sphincter function. It may also tell us the function of the proximal and distal esophagus, and also how the pharynx is working. If we get gastroenterology involved, an endoscopy could be done, and it could tell us whether there is inflammation or esophagitis, as well as gastritis, and again may lead us to what treatment is needed. As far as management, we'll be looking at what positioning may do, dietary changes, medications, thickening, and surgical interventions. One of the first things that we may always do is positioning. Holding the infant upright after a feeding for 30 minutes may help with gastric emptying and make them less likely to vomit. If they are more likely to be in a crib, positioning them on their back or in the right lateral position may actually increase whether the child is refluxing or not. Putting them in a prone position or a left lateral position may actually decrease the frequency of the vomiting or reflux. The prone position, however, can only be done in a monitored unit. We know that having children on their bellies and sleeping is putting them at increased risk for sudden infant death syndrome. Dietary changes. There are so many formulas on the market today. It's overwhelming sometimes to think about it, but the underlying principle is that breast milk is best and that gastric emptying is faster with breast milk, and if we can use that, that is what we like to do. Then we might look at what the casein to whey ratio is of each of the formulas. Increasing the whey ratio may make it more like breast milk, and so perhaps emptying faster. We also might look at what fats are in the formula, whether they have long-chain triglycerides or medium-chain triglycerides. Medium-chain triglycerides will increase gastric emptying. Whether the proteins are hydrolyzed may be beneficial. It's been shown that extensively hydrolyzed proteins can increase gastric emptying time. And then you could use elemental formulas, which are completely broken down, and this may ease the movement of the formula through the gastrointestinal tract. Sometimes we try to increase the caloric density of the formula because we may be struggling with the infant's growth. This may allow us to use a lower volume. So if the child is extremely volume sensitive, this may be helpful and make them more comfortable. Caloric density can also increase diarrhea in the child, though. Osmolarity is another thing that we look at in the formula, and increased osmolarity will increase gastric emptying time. Increasing the caloric density of the formula will usually increase the osmolarity and so may actually increase gastric emptying time. The increased osmolarity of the formula may also lead to looser stools. Medications that we might think about using would be something to help stimulate the gastrointestinal tract to move a little faster. One of the main medicines that's used in infants is erythromycin. It is an antibiotic. It does work to stimulate gastric emptying and has been shown to help in premature infants. Acid-reducing medications could be the H2 blockers or proton pump inhibitors. We typically would only use these if we thought that there was acid reflux happening based on studies that we've done. Another medication that we use to decrease the lower esophageal sphincter openings is baclofen. And baclofen can be helpful in that lessening of the openings. One of the challenges with baclofen, though, is it can be sedating, and we do not want the child missing out on developmental opportunities because they're always sleepy. Another medicine that we might use is an antihistamine called cyproheptadine. Cyproheptadine has been shown to allow the stomach to expand or accommodate larger volumes in some infants. which can be helpful. It also can decrease to the overall hypersensitivity of the gastrointestinal tract and can be very helpful in that situation as well. One of the problems with cyproheptadine is that it can be sedating. And again, we don't want the infant to be sleeping throughout the day. In some cases, it can make children irritable, in which case we would not want to use that medication. We may use thickened formulas to help with decreasing vomiting. And the reason that this works is because it increases the viscosity in the formula. And the other reason that we might use thickened formulas is to aid the infant to aspirate, which is beyond the scope of this talk today. Thickened formula has been used as a way to decrease vomiting in infants. There was a meta-analysis done by Horvath et al. In 2008, in which they found that the use of thickened formulas compared with standard formulas increased the number of infants who did not vomit. They had increased weight gain per day. It had no effect on the reflux index, which is the number of acid gastroesophageal reflux episodes per hour, or on the number of episodes lasting greater than 5 minutes, but it did significantly reduce the duration of the longest reflux episodes where the pH was less than 4. In their study, it showed that it could be of benefit. In another study by Salvatore et al. In 2018, they actually looked at commercial thickeners compared with thickened standard formulas and found that the commercial thickeners resulted in a better viscosity and also better digestibility, and there was a better nutritional balance. Both types of thickened formulas, the commercial thickener as well as the standard formulas that were thickened with additives, did reduce vomiting. In our practice, we have had increased success with the formulas. One of the challenges with premature infants is that they need higher macro and micronutrients, and with these formulas, they are not formulated to meet those needs. So we may have to try to meet those needs in another way. These formulas may not be easily available to some of our families. It may take a prescription to be able for them to get this formula from the WIC program, or Women, Infant, and Children program. And we don't really have studies in premature infants per se. Some of the disadvantages to thickened formulas in the NICU are, again, they're not well studied in the premature infants. There has been particular concerns after the xanthan gum thickener was associated with necrotizing enterocolitis, and really brought into question how much do we really know about these thickeners and using them in our most vulnerable infants who already have medical challenges affecting their GI tract. There also has been concern about arsenic in rice cereal, and that when we use the rice cereal to thicken formula, it's in quite a bit more density than an adult eating rice, and the arsenic exposure. So the American Academy has really recommended that we try to steer away from the rice cereal, or to alternate it with other types of cereals like barley, oatmeal, or multigrain. Our dietitians have had concerns for many years about thickening and how this changes the nutritional balance in formula, whether it's for kids who are premature or healthy term infants. This has been a concern. The use of carbohydrates in babies with chronic lung disease may be contraindicated. And so our pulmonologists and neonatologists who follow babies with bronchopulmonary dysplasia may not want us to do this. Thickening the formula may cause constipation. Constipation can make vomiting worse. So we need to watch out for this. Many of our families have difficulty with the feeding pump. This seems to vary. Some of our families seem to struggle with this a lot, and others seem to be able to work it out and figure out how to make the pump handle the thickened formula. Other options to think about as far as trying to help babies with their struggles with vomiting is use of nasogastric feedings, and then the possibility of a nasal-jejunal feeding if all other things are not helping. The nasal-jejunal feeding takes the delivery of the feeding past the stomach and into the small intestine. So definitely is effective for decreasing kids who are volume sensitive, but we have to give these feedings on a continual basis, and so they don't get time off of the pump to allow their gut to rest. This has some challenges for when they're having their therapies and other things that are going on, and also may not be developmentally appropriate for them. Also having the tube in the jejunum, if they're going home, means that they have to come in to radiology to have that tube placed because it cannot be placed either by a nurse at home or in the emergency room. Surgical interventions are usually the last consideration when we're working with children who have reflux or vomiting in general. The Nissen fundoplication is the standard procedure that the surgeons would do. Some of the problems children have after the fundoplication, though, is they can have retching and gagging, and this can be almost as concerning to the families as the vomiting was. They can have more feeding intolerance, again, because of that retching and gagging. And so many institutions are not doing the fundoplication very often. So after we've achieved the best management of vomiting on a way to feed the infants in the NICU and they're ready to go home, we need to offer the family continued support once they are home. One of our biggest things that we need to do for families is to listen. Feeding intolerance is one of the most common challenges that families face after they get home from the NICU. It's not infrequent that I hear from families that they were doing okay in the NICU for the last week before they went home, and then once they got home, the child started vomiting after every feeding. Is this because the environment at home is a little more stressful for them? Are they getting the feedings faster? It's unclear, but it's not uncommon for us to get that complaint from families. The vomiting is very frustrating for them. Again, they have to watch their child experience something that is not comfortable. A lot of times then the child is not growing well because they're not tolerating the feedings. Because of that poor growth, when they come into the clinic, the team may say we need to do something different. That may be either changing the caloric density of the formula, or that may be increasing the volume of the formula. Sometimes that leads to better success. Sometimes it might lead to actually more vomiting. So it can be a vicious cycle that, again, is very frustrating for families. If the child is eating orally, this intolerance over time may lead to prolonged feeding and feeding refusal. It's not uncommon for families to report that they're feeding kids for up to an hour and doing that several times a day. So they're really spending much of their time trying to feed their infant. If they have other children, this can be very disruptive to the household and again lead to much frustration. One of the biggest things we need to do is monitor the child's growth. This is extremely important for the best developmental outcomes for these infants. We need to base that growth on their corrected age until they're between 2 and 3 years old. This usually means that they are requiring higher caloric needs than their term healthy counterparts. It's important that we use disease-specific growth charts where those are needed, such as in children with Down syndrome, children with Prader-Willi syndrome, CHARD syndrome, have their own specific growth charts that we need to look at. This, again, is frustrating sometimes for families. They feel like they're doing everything that they possibly can to help their child get the feedings as they were instructed to do, and then to come into clinic and find out that they're not growing can be challenging, and sometimes it's hard to understand why their infants need these extra calories. So we need to, again, listen and try to support them and understand why their children need these extra things. It is important to watch what medications the children are on. If we decided to use medications to help treat their vomiting, if they had gastroesophageal reflux disease, some of these medications can have side effects. In particular, the proton pump inhibitors can have long-term side effects. It can affect absorption of different nutrients. It can affect bone density. May have effect on the immune system, and so we need to watch this. At different times, we need to try the kids off of the medicines and see if they're able to maintain the status of not vomiting or experiencing reflux. It would be important, though, not to try them off their medications when they're at transition stages. This would be if they're a tube feeder who is in the process of working on bottle intake, and this is going well, I would not stop their medications at that point in time. If they're at a point where they are beginning to offer or to be offered baby food, again, that's a time I would not stop the medications. Transition to table food is another time. I had one family where the child actually was doing very well once they had come home from the hospital. The child was on a proton pump inhibitor and cyproheptadine. He was taking his bottles well, was not throwing up anymore. Parents were extremely happy. When it came for him to start taking baby foods, we didn't really think he was going to have a problem, but when he started taking them, he started having gagging. We worked through it by offering him small amounts of food and having him get used to it. but we did not take him off of his medications. And then eventually we were able to start him eating table foods. We need to also consider when we might wean the child off of their thickening agents, or whether they're on a formula that is already thickened. There is concern about the effect on the macro micronutrients, and long-term what that will mean for the child. There sometimes are many extra calories that are associated with thickening the formula with something like rice cereal or oatmeal, and these kids can be growing very rapidly. If we reduce the amount of formula that they take, then they're going to get even less of their macro and micronutrients that they need, and this would not be good for them. So we need to get that out of there as soon as we can and get them started on other foods that can help them. Usually we like to follow these kids until they have transitioned to a regular diet. So that may mean until they're toddlers. Many kids who were in the NICU and struggled with vomiting have challenges making the transitions to baby food and then to table food. And it's one of the reasons that they end up being seen in our Comprehensive Pediatric Feeding Program is because they do not make these transitions. So if we can stay with the families and help coach them through those times, we're much more likely to have the child make those transitions and not end up with a pediatric feeding problem where they're having lots of food refusals and many struggles. All right, now we're going to have a case presentation to see if we can show some of the points that were made during the presentation. So this child is an infant male who is born at 29 3/7 weeks gestation. So that's one risk factor for this child to have problems with vomiting and leading to feeding challenges. Mom was a 22-year-old, and this is her first child, and she has a history of alcohol abuse. She also is on biotin, esomeprazole, which is a proton pump inhibitor, some probiotics, and levothyroxine for hypothyroidism. This child has a known congenital diaphragmatic hernia, so another risk factor for us as far as having GI motility problems and vomiting. This is a vaginal delivery. APGAR scores were 1 at 1 minute, 1 at 5 minutes, and 5 at 10 minutes. Those are low scores. They are based out of a scale of 10. So there was some birth suppression. The infant was floppy and apneic. The child did require resuscitation in the delivery room, and then the child was transferred to the Children's Hospital. The Children's Hospital does not have, is not connected to a delivering hospital. So the child was managed in the NICU. He did go on to develop bronchopulmonary dysplasia. There was repair of his congenital diaphragmatic hernia at 1 month of age. But he was on total parenteral nutrition for some of that time, and he did develop some cholestasis and was managed by gastroenterology, and it did improve. There were multiple attempts to wean him off oxygen, but these were unsuccessful, and this felt to be related to many things, one being his prematurity, but also the fact that he was not tolerating feeding as well, was having feeding intolerance and vomiting. He was getting developmental care, which all of the infants get in the NICU. There was a physical therapist who was following him. There was a speech therapist who was working with him on oral motor skill development and sensation. There's a music therapist who saw him regularly, as well as a massage therapist. The nursing and speech and language pathologists worked on the oral motor stimulation and the oral feeding attempts. He had persistent vomiting many times throughout the day, many times unprovoked, but certainly when he was engaging in activities, he would vomit. He started refusing the bottle, having arching and pushing away. There was gagging with most attempts with anything in his mouth. He was crying when he was presented with a bottle, and when put even in the cradle position, he would start crying. So consultation was made to the neonatal feeding team to assess frequent emesis and the possibility of him having gastroesophageal reflux disease, and then also evaluating whether he was having adequate airway protection from these events of vomiting and during his oral attempts. So think about the risk factors that this child has for vomiting and feeding problems. As mentioned, prematurity is one of those. These children usually have many other things going on that their body is trying to deal with, and handling food in their stomach is not one of them. Things move slower through the gastrointestinal tract. He also had some birth asphyxia, which may be contributing to some of the reasons for his problems. He was born with an abdominal defect, the congenital diaphragmatic hernia. We know that those kids can have airway issues as well as gastrointestinal issues, particularly poor motility. And he went on to develop bronchopulmonary dysplasia requiring oxygen, and we know that those children also have issues with their gastrointestinal tract many times. So the vomiting certainly was affecting this infant's quality of life. There was significant gagging with anything that really went on in his mouth or near his mouth. This was creating hypersensitivity for him as well as for his caregivers. There was poor growth because they couldn't advance his feedings the way they would have liked to. Certainly interruption in his therapies because when they would come and try to get him to move around and get in different positions, this could evoke vomiting. Stress for the family. Certainly this is one of the big reasons that the family stayed in the hospital longer, was because they could not get him to tolerate feedings well, and required multiple assessments, and then it interferes with feeding development, and of course that's a major issue for these children, and one thing that families are hopeful for. So his assessment went on to involve evaluation by the neonatal feeding team. They requested an upper gastrointestinal tract study, an abdominal ultrasound, esophageal manometry, as well as pH and impedance study. And then also a consultation with the Comprehensive Pediatric Feeding Program, one for medication applications to try to control the vomiting, but also to get to know the child, because that's who would be following him when he went home. And of course, physical exam with this. So when I evaluated the child, he was with his grandmother, and he was in the process of getting a feeding. At this time, feedings were being given over 45 minutes. He was very alert. He would look around. He would look at you. He would look at his grandmother. He had a nasal cannula for oxygen in his nose. At that time, he still had a NG tube and had not gotten his G tube placed yet. He was bringing his hands to his mouth. He didn't put them in his mouth a lot, but they certainly were up towards his mouth. And during this 20-minute observation, he then started to thrust his tongue. He had a gag, but he didn't vomit at that time. He would go back to looking at you and being interactive, and then would have another gag, usually beginning with thrusting his tongue. He would pull his legs up. He did then pass a large stool during the feeding as well. He did not cry out, but he did look uncomfortable during much of this. His tone otherwise seemed normal. He did not have any other abnormal movements, no tremor, clonus, other abnormal neurologic kinds of things going on. So with his pH impedance study, he had a reflex index of 2.6. Normal is less than 3. Recommendations from the manometry study were that he had dysmature reflexes and that it would take time to get to full efficiency. He had limited endurance, the bronchopulmonary dysplasia, and the congenital diaphragmatic hernia that certainly influenced the problem with the reflexes. They recommended offering a slow flow nipple with limited volume at this time. His negativity with the bottle presentation was severe, and the therapist really felt it was not wise to continue offering the bottle as a pacifier until after the gastrostomy tube was placed. His vomiting was not due to acid reflux, so no anti-reflux therapy was started. He was started on erythromycin as a pro-motility agent, and this was tried for several weeks, increasing the dosages, but there was not significant improvement. Finally, we decided to try cyproheptadine at a low dose, and that seems to have helped. This helped with his gastrointestinal hypersensitivity and with gastric accommodation. And then at that point, the gastrostomy tube was placed. After he was tolerating feedings, it was then decided that he could go home. He had follow-up in the first week with the bronchopulmonary dysplasia clinic. And then in the second week, he was seen in the feeding clinic. He was then about 4 months corrected age, was tolerating feedings fairly well. He would get 4 boluses during the day and a 10-hour drip at night. He would have been continued on the cyproheptadine. He was still vomiting 2 to 3 times a day, but this was significantly improved. He was putting his hands in his mouth and there was decreased gagging. Mom felt that she should try to offer some taste, which she did, of applesauce on her finger. He did not gag. He seemed to like it. His growth had been good. Therapy had not gotten started yet, but they were going to be getting that closer to home. They lived about an hour away from the Children's Hospital. On sending him home, it was decided to begin with an extra slow flow nipple, present it dry at first, and then to start with 5 mL of formula and see if he could begin to tolerate that. And he will have follow-up in about a month. That is the end of the case presentation. The little guy seems to be doing pretty well. I'd like to thank you very much for your attention today. in our discussion about vomiting in the NICU population.
Your presentation was informative and insightful. We truly appreciate your expertise. We will now move on to the question and answer portion of the webinar. For questions we do not have time for, we will post them on the website along with the recorded webinar. Dr. Burdo-Hartman, are you ready for a few questions?
Yes, I am.
Okay, we have one question that a lot of them are regarding thickening, of course. What formulas are you referring to? I think when they were talking about thickened formulas, so maybe somebody's wanting specific.
Yeah, so the two big ones in the United States are Enfamil AR and Similac Spit Up, where it's part of the formulation that those formulas, when they get into the stomach, will become thicker. And so, some of the studies showed that because it didn't rely on human to mix the formula and then add the cereal or whatever, that they're a little more stable when it comes to what the nutrients are and the caloric density and all that kind of stuff. But those are the two major formulas.
Okay, great. Another one is, what is the concern regarding thickening the carbohydrates provided to infants with chronic lung disease?
So one of the things that happens with your lungs is that you blow off carbon dioxide, and if we have excess load of carbohydrate, then those infants don't always get rid of that, and they can have a buildup of carbon dioxide in their system, and they already tend to have high carbon dioxide.
Okay, thanks. How about, are there any age restrictions to use of the pre-thickened formula?
There are not. So again, the big thing is that, for the preemie infant, if they are requiring, a lot of extra calories, it's hard to get that sometimes with those formulas. You're only supposed to thicken or to increase their caloric density up to 24 calories per ounce. But otherwise, if you're working with, term infants or anything, they can have those formulas right away.
Okay, thank you. We have time for just a couple of quick more questions. What are your thoughts on using gabapentin for GI hypersensitivity?
Yeah, so first we work through everything else. So, looking at any other reasons that might be going on with the child having that discomfort. But then if we have looked at everything else and it really does seem to be more of a hypersensitivity or visceral hyperalgesia, then I will use gabapentin, starting out at pretty low doses, 5 milligrams per kilo per day. And then I usually like to wait at least a week before I would try increasing, because I think it takes a little bit of time for the receptors, the GABA receptors, to get mediated and everything like that. But we do, in some infants, use gabapentin.
Okay, thanks. We have time for one more. And again, you guys, if we don't get to the questions that you've asked, because people are asking great questions, they will be on our website afterwards. But let's take one more. Is it true that pre-thickened formulas do not work if the patient is on reflux meds because there is no stomach acid to mix with?
So that is theoretically true. Sometimes, though, we have noticed that, particularly if we're concentrating the formula, the kids do still seem to get some benefit from those formulas. And I don't know that, depending on the dose of proton pump inhibitors that's being used, there still may be a little bit of stomach acid present to activate the formula.
Okay, thank you so much. We have run out of time. Thank you again, Dr. Burdo-Hartman. This is great information for all of us. As we wrap up this presentation, Dr. Brown's Medical would like to thank Dr. Burdo-Hartman again, as well as all of our attendees. In July, we will have a special webinar to prepare for the first week of August World Breastfeeding Week. So keep your eye out soon for an announcement and registration for this informative webinar. Have a great day, everyone. Bye-bye.